All right, everyone. Good to see everybody again. This will be the last lecture that I record for you guys for this COMAT review series. This covers up the kind of the altered mental status portion of this section here for me. It's been a lot of fun. Would appreciate you guys' feedback. Let me know if you guys how you guys like these lectures, and if you'd like us to do more or expand on certain topics. Please let us know. All right, with that being said, let's dive into syncope. So syncope, as far as from a test-taking perspective, man, can cover a whole broad range on a differential diagnosis. We've covered syncope with chest pain. You know, you think about a pulmonary embolism, aortic dissection. You think of sepsis, hemorrhagic shock, loads of things with syncope. And to narrow it down for this lecture, we're going to focus on just strict syncope and kind of returning back to baseline. Which is what the definition of syncope really is. So you get this transient loss of consciousness that returns to baseline neurologic function. Common confusers that will come in will be a seizure, neurologic conditions, right? So seizures, you get that post-ictal state. And if it's a true neurologic condition, like what we talked about in the stroke and the seizure lecture, if you're not coming back to baseline, there's something else going on. So did we pass out, lose consciousness, and we remained altered? Do we think there's hypoglycemia? Do we think there's hyponatremia? Is there persisting focal neurologic deficits that make us think that there's like an intracerebral hemorrhage or mass effect that's going on? So what we're talking about here is not that, right? So when you're going through these test questions and it's 50-year-old male that presents with syncope, you have to rule out all these big, bad, scary ones. So you think of shock, hemorrhagic, cardiogenic. I mean, you could throw all the shocks in there. Shortness of breath, chest pain, syncope, think pulmonary embolism. Are they tachycardic, tachypnic, hypoxic? Was there, a 50-year-old male, chest pain, sudden onset, ripping, tearing to my back, now syncopized, it's a dissection. Worst headache of my life, syncope, subarachnoid. Female childbearing age, you think ruptured ectopic pregnancy, elderly gentleman greater than 50 years old, history of tobacco abuse, pulsatile mass on exam, syncope, it's AAA, right? Melena. So there's other things that go on these question stem that will clue you into syncope as far as how to go down the pathway, how to navigate through those question stems. But what we're going to do here is focus mainly on the arrhythmias that can cause syncope, and the real common ones that you'll get on a test question is, hey, here's young, otherwise healthy individual who had a loss of consciousness, returned to baseline, got an EKG. What do we see and what should we do about it? But before we get to that point, there is one common heart murmur that classically associated with syncope, and that's aortic stenosis. So on exam, elderly gentleman, 60 years of age, presents with syncope on examination, right upper sternal border. You got a crescendo, decrescendo, systolic murmur, radiates to the carotids, complains of some shortness of breath, persisting syncope. What is the most likely diagnosis? You're looking for that aortic stenosis there. Treatments that we typically do, give preload, help open that up, avoid any sort of vasodilators that would drop preload, and then admission, looking for a valve replacement. Big one as far as the cardiac murmurs go with associated syncope. Now get into the fun stuff, the EKGs. So there's 5 of them that we cover here, and anytime you have someone that presents to the emergency department or in a question stem, presents to the emergency department with syncope, reflexes, you always think about an EKG. What am I going to see on it? Starting with number 1 is Brugada syndrome. Most commonly caused, young, otherwise healthy female, comes in syncope. You get the EKG and you see this ST segment elevation followed by a negative T wave, and it's usually seen in these precordial leads here. What's the pathophysiology behind it? I've seen that question. It's a sodium channelopathy. That's what causes that kind of that wide and that ST segment abnormality there. And what is the treatment of choice? You got to get an ICD placement. There's different types of Brugadas and different, clinical different EKG presentations, but this by far is the most common one that I've seen pop up on test questions. Next one is prolonged QT intervals. We talked about this in the electrolyte lecture, right? So hypocalcemia, hypomagnesemia, hypocalcemia, hypothermia, a couple medications. There's a whole slew of medicines that prolong QT interval, right? And then a lot of this is looking for the underlying cause. Is this a fluoroquinolone that's doing it? Is this a zithromycin? Is this an antipsychotic medication? Is this an antiemetic medication that's going on? And so a lot of that could be, here's the EKG, what medicine is associated with, the attached EKG, and looking for that prolonged QT interval and then a medicine that can cause that. As far as this EKG I have up here, so this is with hypocalcemia. So it does have that prolonged QT interval, but you also have that associated U wave that we talked about in the electrolyte lecture. But just to bring it in again here, you get that prolonged QT interval and then an additional wave there, and that's that U wave saying, hey, this could be low potassium. The next one here is another prolonged QT interval. So again, we're measuring this from the R to R and then where the termination of that T wave is, which is about here, which is a very prolonged QT interval. This one is from hypocalcemia. You usually get a prolonged ST segment that then goes into your T wave there. And then this one here, you're looking for like hypothermia. So there's something called like an Osborne wave that you see at the J point. And that's this right here that kind of clues you in. Also, the question stem would also help as well. 50-year-old gentleman found down in the middle of winter. He's hypothermic. This is the EKG. What would you like to do? Well, let's warm the gentleman up. So the majority of this is, what is the underlying cause, and let's fix it. What if it's congenital? Congenital prolonged QT interval. And that situation kind of changes, right? So there's not an underlying cause that we're going here. So for us, it'd be, some sort of beta blocker. So propranolol or nadolol is usually what see come up in the past, and that's usually a pediatric patient. And then from there, it'd be following up with the appropriate specialists for further intervention. Next one is WPW syndrome, or Wolff-Parkinson-White syndrome. Every ER physician loves to talk about this. Loads of things to discuss here. So the classic thing that we always think about with WPW is that delta wave, so that upstroke, right, that you see here on that PR segment coming up here. That kind of clues you in that there's some sort of accessory pathway that's being utilized. And I like to use this as the example because sometimes it's WPW syndrome and sometimes it's not, but you can still follow the same treatments to get the answer correct. So this is some sort of supraventricular tachycardia. I mean, that something's happening up here, and it's narrow, it's regular. You think AV nodal blockade. That's okay to give. So you get this narrow, regular SVT type syndrome, looking for adenosine. If stable. Unstable, use cardioversion, right? The next one would be a wide and regular tachycardia. So again, here, wide and regular, we always think of ventricular tachycardia. It could be WPW with an accessory pathway that's going an opposite direction and depolarizing ventricles first, and then the atria, which can give you a wide, regular QRS. But because VTAC is so concerning, you just treat it as VTAC. And so if you see this kind of EKG on exam, and it's asking for treatment, patient is stable, amiodarone. If they're unstable, cardioversion. Make it super simple for the test, and these questions come with free easy points. So what if it's WPW syndrome, and you get an EKG, and you're like, man, I have no idea what this is. Well, now they're getting that wide and irregular QRS. This typically occurs when you have a WPW syndrome that then has associated like atrial fibrillation. And you get this very bizarre appearing EKG that pretty much looks like this. And I would say the same thing. I have no idea what's going on. And if they're stable, it's procainamide, which is the classic medicine that we usually associate with WPW. And if it's unstable, it's cardioversion. Makes it real easy, but that's the WPW syndrome. So big things to know. There's an accessory pathway that's formed, and that's the physiology behind it. There's a delta wave that's associated with it when it's rate controlled and you can see it. If it's narrow, AV nodal blockade. If it's wide and regular, treat like VTAC, amiodarone. And if it's wide and irregular, procainamide. And then if any of these are unstable, you give them electricity. Next one that pops up is something called arrhythmogenic right ventricular dysplasia. See it on test questions, never seen it in clinic, but it's there and it's something that we look for. So the physiology behind this is that there's fatty infiltration of the right ventricle, and you get something that's called an epsilon wave, which you can see right over here, or better yet, right up on here on this influx here is what's called an epsilon wave. That's associated with arrhythmogenic right ventricular dysplasia and occurs because of that fatty infiltration on that right ventricle side. Treatment is an implantable cardiac defibrillator. So really what this one is, man, do you know that's EKG or not? And so here's the picture. Most likely to be seen on a test. This seems to be like the common one that appears to be utilized. And then its implantable cardiac defibrillator is the treatment diagnosis, arrhythmogenic right ventricular dysplasia. Last one that can be asked in all sorts of ways: hypertrophic obstructive cardiomyopathy, most common cause of sudden cardiac death, and the murmur is what is unique. And so in the question stem, usually 20-year-old male, otherwise healthy. It's usually with ventricular activity, basketball, right? And you get this syncope that happens. Family history associated with sudden cardiac death. All of these risk factors get played into this question stem, and then they bring on this murmur, right? And you say that, hey, there's a harsh mid-systolic crescendo decrescendo murmur, and it gets louder when the patient stands up. And that's what clues you in on, hey, this is HOCM or hypertrophic obstructive cardiomyopathy. Or, hey, when the patient squats down, the murmur gets less and it gets more quiet. Seen it asked both ways to where, hey, you suspect hypertrophic cardiomyopathy. If the patient squats down, what most likely happens to the murmur? And you have to know it both ways. And so if you think of what HOCM is, it's that that hypertrophied septum that gets pushed into the aortic outflow tract and what causes that murmur to occur. So when you stand up and you drop that preload, then that murmur becomes louder. But if you squat down and you increase that preload and you push that septum over, then you get more opening of the aortic outflow tract, and that murmur goes away. That's how I think of it, and kind of make sense of it all when I'm thinking through that murmur. On EKG, you get those dagger-like Q waves that show up, usually in the inferior lateral lead. So here they are, deep Q waves here, deep Q waves over here and over here. And then treatment beta blocker, calcium channel blocker, and then let's avoid any sort of vigorous physical activity. Other than that, those are the 5 EKG changes that are associated with syncope, otherwise young individuals, plus aortic stenosis is that common heart murmur. And that is all. Thanks, everybody. Been a pleasure.